Okay, so good day, colleagues, and welcome to our session today. As you may be aware, our sharing session is made possible given the funding support from the Gates Foundation to ASLM and partners. My name is Francis Ochen, your session moderator for today. Our housekeeping rules remain, and we will run for 1 hour, slightly over 1 hour. We'll take 3 short presentations and get to the question and answer discussions. Only a few attendees can unmute, and so your only option to participate is through the question and answer space, usually the chat space. We do have language interpretation services. Please keep to either English, French, or Portuguese channels. Our session slides and recordings will be made available to you as soon as they are processed from our side. Colleagues, today we focus on decentralizing diagnosis of multidrug-resistant tuberculosis and extensively drug-resistant tuberculosis in Africa, leveraging on the 10-color GeneXpert systems for improved patient care. We may be aware that the general global TB burden trend remains high, despite multifaceted control efforts that global, regional, and national programs continue to deploy, with, of course, support from partners and technical agencies. The current MDR and XDR-TB trajectory is untoward and poses a significant public health challenges, with, of course, Africa bearing a disproportionately higher burden due to limitation in the scale-up of available molecular tools, among other tools out there. Ironically, some of the limitations are just the indecision to take up some of the evidence-based interventions to full-scale implementation. And could it be because of cost? Could it be feasibility related? Could it be a question of reliability or perceived non-comparability, or just but complacency? And so in today's session, we will walk ourselves through a reintroduction of the 10-color expert systems and its role in timely XDR-TB diagnosis. You may be aware that about a year ago, somewhere in July last year, we ran through this similar session with the developments to the extent it had reached that time. And of course, there are additional developments, and some of those are the things that we'll be sharing in this space. We'll also share some experiences on implementation and scale-up from Ethiopia on still the 10-color system, and some of the considerations for practical transition from the 6-color to the 10-color. And colleagues, to take us through this, we have 3 presenters. Our first presenter is going to be Dipti Lalobai, and Dipti is a familiar person on our platform. She is a manager for medical and scientific affairs at CFID. Dipti will be followed by Julian Dubots, and Julian Dubots is a systems senior product manager, again at CFID. And last but not least, we will listen in from Dr. Ndale Mengesha. And Ndale Mengesha is a senior TB lab diagnostic services advisor with the USAID Eliminate TB program in Ethiopia. And so excited to hand it over to Dipti Lalobai to take us through the first presentation. Dipti, over to you.
Okay, so I think, thank you very much for the opportunity to present again on the XDR TB XDR assay, and certainly looking forward to sharing the information and where we've come up from, as you mentioned, Francis, last year to now, in terms of the XDR assay and its implementation across the different countries. So in terms of, when we look at the burden of disease, we still see a significant gap that remains in diagnosis. And, we have, a current gap of current resistance rates of 400,000 for MDR and of resistant TB incidence. We also have a significant gap in rapid diagnostic implementation across the different regions. And, especially looking at, using the rapid molecular diagnostics recommended by the WHO. So there's still a lot of work to be done, as we know, from reaching the MTB goals. I want to just walk you through a little bit in terms of the CFA product, the WHO guidelines, etc. But first, to start with, just acknowledging the fact that we've reached a new milestone in the global fight against TB with the WHO pre-qualification of the XDR MDR assay, and this designation affirms the test's compliance with WHO rigorous standards for quality, safety, performance, and enables, procurement through different international agencies as well. And then now going into the WHO guidelines and recommendations, there's still strong recommendations that, that imply high sensitivity and evidence to say that we need to put in we need to look at automated NAT testing as a first-line option for diagnosis. And these have further been, classed in terms of classes of product, and they go by low. They go by low complexity, moderate complexity to high complexity. And ultimately, what I want to highlight here is that XDR MTB XDR is the only current WHO recommended low complexity NAT test for both the resistance of isoniazid and second-line anti-TB drugs. And just to reiterate in terms of what the XDR MTB XDR test does, ultimately it's meant as a reflex test. It's a NAT test. It's meant as a reflex test for drug resistance for the INH, ethionamide, and fluoroquinolone in second-line injectables. So, I think there's still evidence and support that enables bringing in a rapid diagnostic at sort of near patient point of care levels of test settings where this technology can still be used with current install bases across different regions with the GeneXpert system. Really summarizing here is the outcomes of the manufacturer independent evaluations that were conducted for the XDR MTB XDR assay, and the analytical performance of the XDR MTB XDR assay pretty much outlines, that it's equivalent to the XDR-TB assay. The sensitivity comes across with high accuracy for ethionamide, for INH, ethionamides, second-line injectables, and fluoroquinolones, as we see listed in the screen box, as well as for heteroresistant detection. This is a recommended WHO diagnostic algorithm, and there's the algorithms start with initial diagnostics, and then further on, go on to talking about how this then filters down in terms of drug susceptibility testing, etc. And again, here the WHO is recommending, low complexity NAT test for both RIF-resistant and RIF-susceptible cases of TB. Just going to touch on a few publications that I'd like to talk about today, and really, highlight performance in this one, looking at a study that was conducted in Uganda that looked at performance of the XDR MTB XDR assay. And overall, you can see quite high sensitivity rates across all the drugs that are listed in this table, as well as, the benefit of having XDR helping to rule out fluoroquinolone resistance for MDR and RIF-resistant TB, which then qualifies, for, the patient for a bedaquiline-based regimen. The XPERT MTB XDR assay also reduces the diagnostic challenges and the dependencies that we have from the highly complex tests, such as, LPA and culture-based assays that are currently in use in a lot of settings. This study looked at a dynamic modeling, and this was done in the Philippines, across WHO data sets from the Philippines and Thailand. And overall looked at, the showed that the universal XPERT XDR testing for all MTB cases showed to be more cost-effective and offers a higher net benefit. When we're looking at the incremental cost-effectiveness ratios per DALYs averted, and also showed high net monetary benefits as well. This study also looked at targeted testing for previously treated cases and is also cost-effective but less impactful. TNGS also has a place, but detects more resistance, but is not cost-effective for routine settings due to its high costs and infrastructure requirements. So a lot of this data really, in terms of the outcomes that they looked at, is a lot of these data can support and look at how healthcare programs can look at improving health impact, looking at it from a programmatic value perspective, where XDR is practical, scalable, and compatible with the existing GeneXpert infrastructure, and also emphasized, policy implications in supporting the XPERT XDR for all TB cases in high burden settings and reserve targeted sequencing for high risk groups, and this will also support reducing the cost. Another study, this was done in South Africa, and they looked at examples of how best to look at a diagnostic cascade for management of TB. And again, on the left-hand side, again, emphasizing that being able to run, following an XPERT MTB RIF assay, your XPERT MTB XDR assay has, again, greater benefit in testing both RIF-resistant as well as RIF-sensitive assays using the XPERT XDR. And if we see on the right, they also, speak to the, show the benefit in terms of being able to put the patient on the right treatment sooner than later, having XPERT XDR as a first-line, drug-resistant test after the ultra assay. This will be an evaluation that was recently published and looked at targeted next-gen sequencing for drug-resistant tuberculosis diagnosis, and looking at what are the implementation considerations when looking at, bacterial load, when looking at regimen selection, how does it fit into the diagnostic algorithm, and where is it best placed? Of course, targeted sequencing, we know, has high success rates in terms of the number, looking at, the success rates in this particular one looked at the, 88 to 93% of samples tested with the sequencing technologies showed good performance. And of course, with broader resistant detection, again, identified resistance of 73 to 86% of the drugs. But again, one needs to consider where is this best placed? How is it practical in high burden settings where we can make the best use of the technologies we currently have to reach the NTB goals? And from this paper, the recommendations really show that XPERT MTB XDR is used as a reflex test for drug-resistant TB, for drug resistance in TB cases. They're also emphasizing that targeted next-gen sequencing is then employed by centralized laboratories for more comprehensive resistant profiling following the preliminary detection by XPERT. And certainly, again, looking at workflows, looking at integrated workflows that enabled prompt and tailored treatment decisions sooner rather than later. So incorporating targeted next-gen sequencing as a follow-up to XPERT XDR enables both faster and more effective treatment, TB treatment, and safeguards the use of novel therapies that we currently have available. We need to protect those because, resistance rates are far increasing in terms of the numbers that we're seeing for bedaquiline, etc. So in summary, I'd just like to say that, rapid diagnostics is needed to close the gap in early detection of TB and reduce undiagnosed cases. Using a low complexity NAT test enables faster, accurate identification of TB and drug resistance, supporting timely treatment. Again, integrating molecular tests and targeted sequencing can provide comprehensive resistance profiling and tailor therapy appropriately. So using rapid tests shows to be more cost-effective in high-burden settings, reserving advanced sequencing for complex and high-risk cases. At this point, I'd like to say thank you so much. And I guess, Francis, we'll take questions after the session.
Exactly. So thank you very much for a very well put presentation there. We will take the questions at the end, and kindly help me deal with some of the questions in the Q&A space so that as we run low on time, we'll have dealt with most of the questions. Dr. Ndele, kindly accept the invite to promote you to a panelist. That's the only way you'll be able to speak and share your screen. Colleagues, we're now glad to have Julian on the platform, and Julian, I'll hand it over to you.
So thank you. I will stay brief because I think that I have like 5 minutes. Today, I would like to update you on the GeneXpert system 10-color technology. So it's something we launched a few years ago, and that is now widely available. Which is very easy, like any new system that we shipped are now 10-color. So you probably have already a lot of 10-color system in the different countries. But the big question is, okay, how can we update the existing install base that might be 6-color to the 10-color? So before we go into the upgrade option, let me summarize why we have these two type of technology and what does that mean. So 6-color technology is what we launched like 10 years ago. And this is the very standard GeneXpert system that you will see. It can run almost all the tests that we have in the current menu, except XDR, okay? To run XDR and to run the future tests that Cepheid will release, you need the 10-color technology. So it's very easy to distinguish if your system can run 10C or 6C by the blue ribbon on the top of the module door, okay? The good news is that 10C, 10-color technology, is backward compatible with 6-color technology. So if you have a 6-color module, you can run any test that is 6-color, meaning the whole portfolio except XDR. If you have a 10-color module, you can run 6-color tests the exact same way. So everything is analyzed in the exact same way, meaning that you can go from one to the other with no distinction. And actually, you can, on top of that, also run the 10-color test. So the 10-color test today is MTB XDR, okay? But we are about to launch new tests because we will exploit these 10-color technology, which is basically additional channels. Okay, so we will have individual call out, but we can go for 10 individual call out and using some specific things in the PCR technology. That means that we can report out up to 40 channels, 40 single call outs, 40 targets, okay? That doesn't mean that we will use the 40, but this is what the technology offers. And actually, a lot of the new tests that we will be releasing in the market starting next year will use this encoder technology. Okay. We don't have much prerequisite for that. And the good thing is actually you can create now hybrid. So it's something we widely validated. Having an hybrid is basically mixing 6C and 10C module into the same box. So I will just pause on that and explain the vocabulary we usually use at Cepheid. A system is what you see on the screen, which is the instrument. The instrument is just the box with the module and the IT, okay, the computer, okay. And hybrid system means that at the beginning it was a 6-color system, and you started to change some or all of the module from 6C to 10C, and then this is hybrid. The only prerequisite we have is that you need to run a version of the software that is fully compatible with the hybrid, and for your reference, the software will be 6.5. Everything we ship today is with 6.5, so it's very easy for you. But if you have an older system, then you might need to upgrade the software, which is free. Okay. Actually, you can do a lot of things with the GeneXpert system. You know that this is a very versatile instrument. So you can mix and match the module inside the same box, but you can also plug multi-box to the same computer. Okay. And you can do that with a small system offering up to 4 modules, 1, 2, 3, or 4. But you can also do that with the 16 version of the system. So on my slide, you can see that we have 1 row with 10 color on the top, 1 row with 6 color on the bottom. But actually, once again, you can mix and match up to your convenience. So you can have like 12, 6, and 4, 10 color. It's up to you. And actually, please keep in mind that the most important when you use a GeneXpert is to ensure that you have a good adequacy of your testing capacity in regards of your activity. Okay, so I will skip that. I don't want to bug you too much with the technical detail, but basically you need to have an up-to-date software. And actually, you know that the world is moving forward. Windows 10 LTLC is the best system we offer today because it's quite secured. And we have this commitment that we will have Microsoft support for a long time. And I know that IT might need to be upgraded, and it's a lot of cost. So we try to support this effort with the computer. Very important is what are the options today? Okay, so I didn't mention that you can buy a new system, and if you buy a new system, it will be a full 10 color. Very easy. But you already have a lot of systems. So you can daisy chain. If you have a system and you just want to add module, but your system is already at full capacity, you can just buy an instrument, so the box with the module, and keep growing your activity or your testing capacity in regard of your activity. You can also do what we call upgrade on demand. So this is, once again, you want to add XDR testing to your lab. You have empty slot in your system, then you can add 1 module or 2 modules. It's up to you, and fill your system with 10 color modules. So you no longer need to invest in the old technology. And what we want is really to focus on the new technology, which is this 10 color technology. Finally, you can also convert the module. If your system is at full capacity, and we know that because of the various crises we had in the past, you may have system at capacity, but you might just need to reshape your system to get access to the new technology without, expanding the capacity furthermore. You can do that by swapping the module. So actually, you will just pay for the technological upgrade, and then it will be quite a minimum investment for you to get access to the technology. Finally, it's something that we support a lot through our service offering. For some countries, we have this ability that to do upgrade on failure. That means that, when a module has an issue, generally what Cepheid does is that we are swapping the module in the field. And for now, we were doing that like for like. So for some countries, because we have local providers for the service and so on, we can actually be proactive in swapping the module from 6C to 10C to support these TB XDR testing locally. So this is where we are. If is just to share. So depending on the country, depending on where we are, we have different solution unlocked. If there is gap, it's okay, and you can work with the local team to address the gap and to change these landscapes. So we are not saying that this is set in stone. It's really something that we want to be dynamic and adjusted to the local needs. That's it for me. So I will probably take the question at the end of the session.
Thank you. Thank you very much, Julian. And we need to be bothered by your hardware and software terminologies, and especially the interplay between the current systems and how we can transition to the 10 color with or without maintenance or sustenance of the current system. So it's very, very important that we understand this. And I know that questions will be coming your way, and do not fear to throw us into some of those terminologies, because if we don't get it now, we'll disturb you in the future. Thank you again very much. And colleagues, keep the questions coming so that experts from CFID and of course the experience sharing from Ethiopia will then deal with those questions at the end. And I know that we are already dealing with some of the questions in the Q&A space. So let me take this opportunity to hand it over to Dr. Ndale, and Dr. Ndale, please get us going with the last segment of this presentation.
Can you see my slides?
Yes. Yes, moving it to the presentation mode. Now? Yes, and take it on from there. Thank you.
Thank you very much. I'm happy to get this opportunity to present the Ethiopian experience on this platform. Thank you so much. So Ethiopia's experience with expert MTB XDR and insights of the effective implementation. This is Ethiopia at a glance. It's more than 126 million population, 1.1 million square kilometer coverage overall the country, total health facility around 21,000, including the health posts, hospitals, health centers, and clinics. Diagnostic laboratories are 44,000 plus. So the health facilities, hospitals are 404 hospitals are available, greater than 5,000 health facilities, and more than 16,000 health posts with no site labs. So massive decentralization of GeneXpert were conducted in the previous years for TB, drug-resistant TB, HIV viral load, and AID services. Routine diagnostics also continued reliance on the microscopy and rapid diagnostic methods at the peripheral laboratories for malaria, AFB, and the like. Connectivity, we have been using LabCoP-Extended connectivity solution for GeneXpert implementation. So the GeneXpert annual growth trajectory and module functionality looks like, as you can see on the figure. So in 2012, it has been 7 machines in Ethiopia. Currently, there are more than 965 GeneXpert machines. Of these 965 GeneXpert machines, 472 of them were 10-color machines that can perform MTB XDR assay, and the module functionality also in the acceptable range, which is more than 90%, currently around 95%. GeneXpert machines annual tests and their contribution for TB case finding, as you can see in the blue background figure 1. And the first figure, so this is the actual number of tests performed throughout the country, even though it has some data quality issues. for the sites were not collected. We expect it will be more than this, but in the 2024, around 731,485 tests were performed, and the contribution, as you can see, it's still sharply increasing and leading the bacteriologically confirmed tests more than 60%. So the Ethiopia's expert MTB XDR scale-up journey, the first why expert MTB XDR assay scale-up was needed in Ethiopia, as it provides rapid treatment guidance. The expert assay provides rapid results for resistance to fluoroquine, second-line drugs, fluoroquinolone, first-line drugs, INH, ethionamide, allowing clinicians to start the correct and optimized treatment regimen immediately, mitigate XDR-TB spread, faster diagnosis of pre-XDR and XDR cases, enable quicker patient isolation and contact tracing, which is crucial for limiting the transmission of highly resistant strains, overcome the phenotypic DST limitations, the key bottlenecks of traditional culture in phenotypic DST or drug susceptibility testing, which is slow, labor-intensive, and limited centralized labs. Universal DST mandate. The test aligns with the national strategy, also the WHO recommendations for the universal access for DST for all high-risk TB patients. And also it helps to optimize high-value resources. Deploying the assay at high-volume GeneXpert sites ensures efficient use of existing molecular infrastructure to get the maximum diagnostic yield at the point of need. In the first phase, as a preparation phase or laying the foundation, during the revision of National Strategic Plan of the MTB, it was included also in the national guideline. It was included and endorsed and disseminated. So next to that, site prioritization and selection was conducted. A total of 122 high priority GeneXpert sites based on the resistance rate and the patient volume were selected. Actually, the number of machines during the initiation of the technology procured were 156, but we have selected 122 high priority sites for implementation, verified operational readiness, functionality, connectivity at all the 122 facilities. So the curriculum and logistics, secured funding, procured the supplies and 10 killer machines. Actually, almost during the initiation period, all is funded by the USAID projects. So we acknowledge the USD funding for this. Develop the standard TOT materials for actually the TOT materials in the training on job as the standard operating procedures job aids were integrated into the national basic training package, and quantification and forecasting also included the MTB XDR assay. In the implementation phase, our execution and scale up, targeted capacity building, executed cascading trainings of lab professionals that include MTB XDR were conducted. Also for the engineers, the preventive maintenance and troubleshooting, which includes also provided for lab professionals or conducted. Cartridge distribution assay following the installation of the 10 killer machines. The supplies were managed properly and the protocols were activated in all 122 sites. Then data integration and reporting, integrated GeneXpert with LabCoP-Extended LIS system, which is a real-time reporting software, which is called the IMTB, through the IMTB project, also USG-funded project, developed the LabCoP-Extended connectivity system, which currently around 888 site GeneXpert machines were ever connected and 650 of them were reporting in real time. Established rapid feedback mechanisms for XDR result to enable immediate clinical action. So the quality assurance also, so we have the national quality system scheme. It's included there. Ongoing monitoring and performance review conducted, the supervisory visits to maintain adherence and troubleshooting operational issues. Continuously track the performance against the national KPIs, aiming the 100% second line DST testing compliance. So major achievement is 98% of resistance cases are tested for second line drug. So the strategic development in all 122 high need facilities, MTB XDR assay deployed, rollout achieved across all major regions of the country. Advanced testing compliance uses either the MTB XDR assay as a primary in the facility. For further and detailed investigation, phenotypic DST will be requested. Informed clinical care, high linkage, ensures data-driven treatment. Susceptibility data informs care for most critical drug resistance patients. So the critical management leads to this. In addition to reflex tests for rifampicin resistance, we have also used in additional 71 health GeneXpert single sites. We have tested in 2 months period, 841 registered rifampicin susceptible TB patients to see the INH monoresistance prevalence among registered RR susceptible TB cases. So we found and identified that 2.8% of rifampicin susceptible TB patients were INH monoresistance by using MTB XDR assay as a primary, as a major gaps and challenges. Infrastructure, for example, for power backup, around 61 facilities are lack of power backups. So actually there is a huge plan that to cover this one. So it was under in the process of procurement to cover this. The logistic and supply the short cartridge shelf life leading to expiration. So due to that, to utilize the near expiry that we conducted in 71 additional sites for RIF susceptible TB registered TB patients, and we found a 6.6 as I previously told you. So operational and quality assurance issue, also integration and achieving the national target in AKWay implementation is one of the components. Addressing all GeneXpert machines through the national PT system, human resource and awareness, trained staff shortages are available, so this should have to be mitigated. Limited clinical awareness leads to underutilization and inappropriate requests. Technical and data gaps, the low sensitivity for the MTB detection and possible ancillary samples leads to some questions and heading to us to respond to such disagreements with the MTB XDR Ultra cartridge one. So as a recommendation, the infrastructure and power instability, investment for a stable power backup is actually under an process. In the near future, it will be fixed. I know the details at the national level. Enforce the equipment service level agreement, by the way, a service level agreement supported us a lot, as I showed on the the first slide on the service slide. I think the module uptime is high in the acceptable range, even though it is high, around 8%, where there is a fluctuation for limited periods. This should have to be fixed. Logistic system in real time, active lab, the LIS system should have to be addressed. secure the supply system, technical data gaps, reinforce the testing algorithm, resolve the connectivity issues to bring all sites 100% in a real-time reporting system, operational and quality issue, and human resource and awareness also should be addressed. So I would like to acknowledge the National TB Program, the Ministry, the Ethiopian Public Health Institute, the Eliminate TB Project is our project, and regional health bureaus for this all. I thank. This is all from my side. Thank you very much. Over to you, please.
Excellent. And thank you very much for that experience sharing. And as you may have noted, there are so many questions coming through in the chat related to the performance of the platform, but also people wanting to get additional insights from your experience, Dr. Ndale, from Ethiopia. And before you rest, can I just throw out one in the works? And that question that is running around is on the performance in terms of sensitivity of the 10 color. And because it's a reflex design platform, it's not as sensitive as the 6 color. And therefore, some of the samples that are being reflexed end up being picked as MTB not detected. And I just wanted to hear from your side before I get to the CFID colleagues. What has been your experience in your implementation and scale up? Are you seeing a lot of this? Do you have some cutoffs of which sample results are reflexed? Are you reflexing all the trace and the high positivities, or you have some categories that you're reflexing? Just your insights before I go to some technical details from my colleagues from CFID.
Thank you very much, Hossein. It's a great question. Actually, we have experienced a lot of challenges due to this, especially for the understanding of the assay and the 2 10-color and 6-color machines. The assay, MTB XDR assay, was taught already. The 10-color is taught with aligned with the XDR cartridge, but the platforms are the upgrade of the 6-color to 10-color. It can perform all the tests. And when we come to the assay, to the cartridge, the Ultra one is higher sensitive, and this one is for the MTB version. It's the sensitivity is lower, so that we have been encountering such a challenge, but we are without cutoff point. We are using for all, but there is a discordant result which is initially MTB detected ref resistance. When we come to the MTB XDR, it will be sometimes MTB not detected due to the concentration of bacilli in the sputum. So following this, for those trace results, actually trace results are usually indeterminate for rifampicin resistance. They are not eligible for the reflex testing because since we can't get the ref status. But for the others, we are using without the cutoff point. But for those postbacillary TB cases in very low category, we have been facing this negative results, but we are heading by checking again with ref status for those facilities, for those patients specifically presumed of pre-XDR or XDR cases. And if it comes negative with MTB XDR, we will follow the national guideline, which guides us to the phenotypic DST. Thank you very much.
Thank you very much. And Deepti and Julian, just your addition to this, and how much guidance is being provided to users out there on how to better utilize this very, very important tool. We do know that perfection is never going to be the enemy of the good in this case, but what guidance is being provided, and is this available to every user out there?
Julian, I'll take this one, but I think ultimately we do explain this in our package insert for the XGeneXpert MTB XDR assay. And as Dr. Ndala just said, it's really important to take this into context for every case, because low bacillary load are due to multiple different types of reasons. That is it a previous infection, a poor sample quality, if the sample wasn't homogenized correctly or appropriately before testing or splitting, that can also give you, these types of issues. But a lot of this is covered during our training, and if there's anybody that needs any more specific information or advice on this, we can certainly support them.
Excellent. Julian, I don't know if you want to add anything to that, because we've had so many questions in that regard.
No, nothing to add on this one.
Great. So let me hold it with you, Julian, and this relates to really the swapping of modules and especially those that are deemed no longer to be usable. So the 6 color that should then be swapped to 10 colors. And Mulenga is asking if this swapping, that guide, has reached most of your distributors out there, so that then the country users are not struggling with some of your distributors out there with regard to swapping some of their modules to 10 color from 6 color.
Yeah, this is a very good question and a very important topic. So I just started to answer to the question, but I will do it live. We can do so, and it's already live in various countries. So you saw the list at the end of the presentation. Once again, it's not set in stone. So if it has to be extended for various reasons, please refer that to your local partner and ask them to escalate that to me, so we can work on wider deployment. You have to be vigilant that, because of some of the technical concern that you have to take into account, especially the software version, sometimes it's not doable to do that. So if you have a very old system, or if the software is tied to some additional things in your lab, like your LIS or anything like that, it might require additional time on site. And depending on how critical is the failure, we need to find the right balance between restoring your activity, which is generally crucial, and deploying the new technology. But short story, yes, it's doable. Long story is that we are working very closely with our local partner to ensure that they have the right information, they know when to update the software, and they also get access to the module. So this is something we can deploy more and more.
Great, and let me keep it with you before I let you go, and I bring in Deepti. So Momeka, I hope I get the name right, he or she is asking, the new platforms, do you have the options of placing them as on a reagent rental basis, or they are generally outright purchases?
I'm going to leave Julian to answer that one in terms of the module and cost implications. Yeah.
So,
it's okay, Francis.
Yeah, I'm not fully up to speed on what we do in each specific country, and especially in Zambia. But this is something we can do. So we have multiple ways to get you access to the technology. So you can actually do capital investment, and you did that a lot in the past. But it's also okay to consider what we call reagent rental. So which is basically that you pay for the system, for the test, sorry, and not for the system. and it's based on a business case. So it's something to discuss with the commercial team, and we are, so it's something to discuss with the commercial team. But what is very important is you need to have a legal entity in the country to make it happen. So that's why capital purchase is generally what you do.
Great. And Dipti, you might take this, but if you want Julian to help you with, you can as well. And Julius, the gentleman Julius is asking if we know already what proportion of our 6-color cartridges have now been transitioned to the 10-color. I will add to that and ask what our targets are, because probably we do know epidemiologically what our anticipated XDR-TB numbers should look like against the susceptible TB, of course, against the multidrug-resistant TB as well. And so do we have a target of what proportion we're targeting to transition from the current 6-color to 10-color? And how far have we gone in achieving that, if we have some numbers to share?
Yeah, I mean, okay, leave it. No, you can go ahead.
I will go, but generally I like to provide answers that are very crystal clear, very obvious. It might be tough on this one because the thing is, globally, if you look at the whole region, I guess we are between 40 and 50% of 10-color capable system, but it won't give you any insight on how they are, what is the split of this system across the country, and whether they are located at the right place or not. So I think we need to run something a bit more details on where is the need, what do we have, and how we transition your install base from the current status to something that is actually fully aligned with your needs. Because if you just look at the scale of a country, you will have a percentage, but you can't tell whether the 10-color module are at the right place. But the good news is that the system is quite flexible, so we just have to be very creative in our approach and make it happen. And we can help on that.
Great. And Dipti, if you have anything to add to that, you're more than welcome to do that.
Yeah, I mean, I think Julian's answered it pretty much. It really is about how to enable the system to be, testing and making sure that you've got sufficient capacity to be able to do the testing of XDR. And really, it depends on how many positive cases you will be reflexing to XDR as well.
Great. And I will take you to this direction, and hopefully you can provide some insight. So we do have other molecular platforms out there that may not even be picking RIF resistance. And so they're just picking out the MTB. Should these platforms, near point of care and other lower level platforms, should they first be reflexed on the 6-color before they are reflexed on the 10-color? And because then if the cost implication to direct reflexing onto the 10-color is significant, and yet our being able to pick XDR resistance, probably the proportion is lower, then given the costing and the cost dynamics involved, would you encourage that if somebody is just detecting TB and not disaggregating by either monoresistance, multi-resistance, or extensive resistance, they should flex to the middle category before they go to the extreme category?
Yeah, I mean, you can't do anything without knowing what your first line data is telling you, right, in terms of the RIF resistance, etc. So up to now, there's been, the use of RIF resistance as a frontline has certainly helped programs with initiating treatment right at the onset of getting a result at near patient testing, environments, but it is recommended to have both RIF resistance as well. So it is important that you have to go on to confirming that, because, you know, having a TB result by itself, you know, which way do you go from there? You still need to know what drug resistance is to enable the right treatment.
Thank you. Thank you very much. And now our time is fast spent. Our chat is buzzing, and I can assure everyone that we will pick all the questions here and make them available to our colleagues at CFID or the Ethiopian team so that they can address most of these questions. But before we just wrap it up, we'll borrow about a minute or two from our delegates who are attending. The question related to external quality assessment and PT panels. Could there be some of the panels out there that are supporting the assessment or objective assessment of quality performance of this very important platform that you know of, or some pipeline developments that you may be aware of?
So are you talking specifically about CFID, or are you talking, I mean, there's many options available on the market in terms of proficiency testing programs.
Especially for XDR-TB, I think that's what...
For XDR-TB specifically, you know, one that comes to mind immediately is the SmartSpot option, and that is something that is quite easily accessible. You know, that is, a lot of countries are using it for the XPERT MTB Ultra assay. We have also validated and tested this program for the XDR assay as well on our systems. So that would be one option.
Excellent. And thank you very much, CFID team. So between the two of you, I'll give you the opportunity to give us your closing remarks. Appreciation really for this very excellent presentation, very loaded, as you can see from the questions, but we'll get you back so that you can continue to decompose some of these for our participants out there, so that this very important tool can be put to the best use and support our people. So your closing remarks, Deepti or Julian.
Okay, I can start. I mean, I think we're all in this together to be able to get to the NTB goals. So we know diagnostics is the greatest and the most significant gap holding and delaying these strategies and goals. So let's put all our efforts together to be able to make a difference for TB. And there's treatment available, so we can certainly get to the end of these goals. Thank you.
Yeah,
thank you very much.
Just to add one word, please consider that the system is just an enablement of the solution. So we need to keep it flexible to address the concern. And for that, they have to be escalated. So it's really nice to be in direct touch with you. And please keep flooding your questions so we can try to address your concern and support you at best.
Excellent. And we totally appreciate the flexibility that this platform provides. And even just the transition from 6-color to 10-color comes with a lot of flexibility. I also want to note that one of your scientists who has been supporting you quite a lot is very appreciative of the work that you've done into deciding and making sure there is the possibility of swapping modules. And that is none other than Willie. Willie was with us in the last session on this 10-color. Can I hand it over to Dr. Ndale to just give us your closing remarks?
Thank you very much, and I'm really pleased to be here and share the experience. I saw a lot of questions were in the question answer areas, but one of the questions that takes my attention, if I can speak on it, I will be happy. We have rolled out XDR MTB rifampicin resistance assay for pediatric TB in almost, it was endorsed before 6 months by the Ministry of Health at country level, and the stool for pediatric TB is performed currently, we are even getting data for 93 health facilities. So since it took my attention, I wanted to speak, and the details of the unsuccessful tests raised in the questions where I already indicated in the presentation. Also, while we are implementing 7.4% of unsuccessful test results that we encountered. So the main code of error is 5006 and 7, so which is related to the incubation and the issue during the sample preparation. So this is it. I'm really thankful. Thank you very much, Osin and the CEFIC team.
Thank you. Thank you very much. And colleagues who are attending, thank you very much for being part of this. You give us the drive to look forward to the next presentation because you come around. Without you, it would not be any meaningful to have this. For those who are asking for additional information on alternative samples for TB testing, we've run a few webinars before, and you can reach out to us or go to the ASLM website and go to resources. You'll be able to see most of these recordings on our websites. But we also appreciate if you can give us suggestions on some of the topics that you're very passionate about, and we'll look out for experts to help us get those to you. And so from us, we're very appreciative of the CFID team. Hope to see you very soon again on this platform. And our colleague from Ethiopia representing the program in Ethiopia. And from us, do have the best of your afternoon, evening, or morning, depending on where you're joining us from.
Thank you.
Thanks a lot for hosting the call.